Good morning, everyone, and welcome to our weekly orthopedic surgery grand rounds. One announcement before we get started. So this Friday, the Gold Humanism Society has designated as Thank a Resident Day. So just in advance, thank you, residents. And no, we really do appreciate all that you do for our patients. It's a privilege to teach you, and we have a great group of residents here at our program. And then for faculty, remember on Friday to thank a resident. So anyone you're working with, definitely make sure to say thank you. You will have a gift. You could pick it up from Johnson, and should be there on Friday, but should be coming soon. So, and then for our speaker today, quite appropriate, introducing one of our residents. So Dr. Hunter Warwick. So Dr. Warwick is originally from Colorado, did his undergraduate work at Brown. He also ran the hurdles, the 110 hurdles, then went to Duke for medical school. He did a sub-I with us here at UCSF. I actually had the privilege of working with him then, and we heavily recruited him to come back to UCSF. And then he's since done a great job as a resident. He's done some great research in arthroplasty and telehealth, received the JOJ research grant for telehealth project specifically. He's currently applying for fellowship in arthroplasty, and then he'll be speaking to us today about efficiency. So Dr. Warwick, thank you, and look forward to your talk.
All right, thank you, Dr. Lansdowne, for your nice introduction. All right, hello, everyone. It's an honor to be here speaking with you all today. We'll be talking about efficiency in orthopedics and some things we might be able to do to improve it. I don't have any financial disclosures. I will say, as Dr. Lansdowne did, that I'm going into arthroplasty, and a lot of the literature on efficiency, and therefore in this talk, is related to arthroplasty, but not all of it, and I still think this topic is relevant for all of us. Here's an overview of what we'll be talking about today. We'll talk about what efficiency is, and we'll discuss some ways of trying to improve it in clinic, the OR, and in pre and post-operative pathways. I'll try to be efficient moving through slides so that we have some time for discussion at the end as well. All right, we're talking about efficiency, so let's define it. In the simplest terms, efficiency is your output divided by your input. Input includes everything from physical materials, energy, time, and financial costs. Output is whatever goods or services you are producing. For us, this is good outcomes. So improving efficiency involves increasing output, decreasing input, or both. I also want to touch on a few things that efficiency is not. Efficiency is not rushing. It's not about going faster. It's about eliminating wasted time, energy, and resources. As the great John Wooden said, be quick, but do not hurry. Efficiency does not come from hurrying up. It comes from knowing what to do and ensuring your actions are controlled and purposeful. And just to clarify, efficiency is different from effectiveness. Effectiveness is the ability to produce a desired result. Efficiency is producing that result with the minimal amount of time and resources. To steal another quote, this time from famous business thinker Peter Drucker, effectiveness is doing the right things. Efficiency is doing things right. So, is efficiency something worth talking about? As orthopedic surgeons, we have the highest clinical volume of any medical or surgical specialty. So being efficient, at least to some degree, is almost fundamental to our job. Also, the high and rising costs of healthcare is no secret at this point, and being more efficient means reducing waste in the system. It also allows for higher clinical productivity. By maximizing our efficiency, we can maximize the number of people we are able to help. Or, in the academic setting, being more efficient can create more time for education and research productivity. Or, going home earlier and spending more time with your family and friends, which can help address the rising levels of burnout being reported in our field. And there are even certain clinical benefits to efficiency, as decreased operative times are associated with lower blood loss and infection risk, and higher volume surgeons and surgery centers have better outcomes. But efficiency isn't always good, and it does not always produce the desired result. For one, efficiency can limit adaptability. Take the Irish potato famine, for example. In the early 19th century, the potato had become the main food supply in Ireland, largely because it was nutrient dense and cheap and easy to grow. In other words, it was a very efficient crop. Even more efficient was growing only the one or two highest yielding strains of potato. But this lack of diversity significantly reduced the genetic variation important in fighting off disease, such as the new strain of water mold that started infecting potato fields in 1845. Coupled with a lack of diversity in actual crop types, this tragically led to severe food supply shortages. Attempts at efficiency can actually create new inefficiencies. The introduction of the electronic medical record was supposed to streamline clinical documentation and make our lives easier. And now it is a major source of inefficiency in the medical system. And efficiency can stifle innovation and new ideas. The most efficient way of doing arthroplasty at an institution would be to standardize everything. Have everyone do the exact same thing. Perform the same hip approach, use the same implant system, balance the knees the same way, and either go all or nothing on robots. But we don't want this. As trainees and as academic surgeons, we want to be exposed to different techniques and ideologies, and we want the freedom to innovate and explore new technology. I do think there are certain things worth standardizing, and we'll talk more about them later, but there are limits we must be wary of. At the end of the day, efficiency is not the answer to every problem, nor is it the enemy of all things good. It is something that can help us, but must be pursued thoughtfully. Now, this concept of efficiency can also seem at odds with our dedication to quality patient care. We're doctors, we're not assembly line workers, and our patients are people. So talking about efficiency can sometimes make us feel uncomfortable. I think it's important to stress that our goal is not just to move patients through clinic faster or perform more surgeries. Our goal is to provide the highest quality of care for our patients, and no strategy or intervention should compromise that. But if we're able to eliminate unwarranted time or costs while maintaining or improving that quality, then I believe we should do that. We'll be looking at efficiency along each step in the surgical process. Patients come from the community into our clinics. Those that are indicated enter into our preoperative pathways. The day of surgery includes pre, intra, and postoperative phases. Patients then enter into our post-op pathway, which includes discharge, medications for pain control and DVT prophylaxis, and rehabilitation with PT. And then they continue to see us in clinic for longitudinal follow-up. So we'll take it from the beginning. Efficiency actually starts before the patient even steps into our clinic. It begins with triage, getting the right patients to the right providers. The ultimate goal of an efficient triage system for orthopedic surgery is minimizing the number of new patients who are not ready for surgery at the time of their first clinic visit. This creates a system in which providers are seeing optimal patient populations for their practice. Getting operative patients to operative providers sooner decreases the time to surgery, and triaging non-op patients to non-op providers not only links these patients with the appropriate care, but it also creates more clinic space for surgeons to see more operative candidates. According to CDC data from 2012, 50 to 60% of orthopedic office visits occurred without a referral from another physician, which means that half the time patients are triaging themselves, which obviously leads to inefficiency. So how do we get patients to the right providers? PCPs referring patients to orthopedic clinics have variable amounts of experience with orthopedic issues. Ideally, PCPs have trialed and exhausted conservative measures prior to referral, or less ideally, they haven't tried anything at all. Education in the form of community lectures or written materials can be helpful in improving utilization of conservative measures for musculoskeletal problems in PCP offices. Another way to improve efficiency in triage is to make sure appropriate studies are ordered and completed prior to clinic visits. This facilitates surgical evaluation and decision-making at the first visit. This also goes for existing patients. It's always frustrating when you see a patient, schedule an MRI, and then when you see them again 4 weeks later, they still don't have an MRI. Partnerships with non-operative orthopedic providers are key in providing appropriate and efficient care, and this must be coupled with appropriate triage systems. One system is to have physical therapists act as gatekeepers for outpatient orthopedic care. This is a popular model in the UK and Australia, and it's gaining traction in Canada. In this system, all patients referred to PCPs are screened by PTs and triaged to either be scheduled with a surgeon or continue appropriate clinical care with a therapist. Studies have found that more than 2/3 of patients referred to orthopedic surgeons can be appropriately managed by PT. There is high agreement between PT and MD in surgical decision-making, and there are high levels of patient satisfaction. Another way of improving triage is with models that predict the need for surgical intervention. This is a study from Cleveland Clinic published in 2020. They administered a questionnaire to all patients calling to request an appointment for shoulder symptoms. The questionnaire asked yes or no questions about chief complaint, associated injury, and prior interventions. Then, regardless of answers, the patient was scheduled with an operative or non-operative provider based on the patient's preference. Then they looked back to see which patients had surgery recommended and developed a model to predict the need for surgery. Overall, 20% of patients were recommended surgery. Predictors of needing surgery were male sex, whether there is an associated injury, and if there was an MRI ordered by another provider. Their model predicts the probability of needing surgery based off these and other variables. For example, a male patient presenting with weakness or instability from an injury who has had an MRI has a 90% chance of needing surgery. Whereas a female patient presenting with pain without an identifiable injury who does not have an MRI just has a 7% chance of needing surgery. Schedulers could use the questionnaire over the phone or online to determine each patient's individualized probability of needing surgery. This information could then be used to create certain threshold values to guide triage to different providers, or it could be shared directly with the patient in order to educate them and inform their own decision. This model is yet to be validated on an outside data set, but I think the fundamental idea behind it is interesting. One thing I think we have to be careful of here is using demographic variables such as sex and race in these triage systems. Male patients being more likely to undergo surgery may have something to do with their injury profile, but it likely also reflects the biases and care disparities that we know exist in our system. And incorporating those into orthopedic triage could exacerbate those inequities. But the use of injury-related variables would seem to be helpful in getting patients to the appropriate providers. Now I'll move on to talking about efficiency in clinic. This is a study from Iowa published in JAOS in 2022. They looked at time spent on the EHR per clinic day for orthopedic surgeons across all subspecialties, as well as other surgical and medical specialties. Orthopedic surgeons saw an average of 31 patients per day. This is compared to 18 patients for other surgical specialties and 12 patients for medical specialties. Orthopedists received an average of 37 patient messages per day, compared to 26 for other surgical and 24 for other medical specialties. And 58% of clinic time was spent on the EHR, which means that only 42% of time was spent with patients. So the majority of our time as clinicians is being spent on the computer. I'm not sure this comes as too much of a surprise to anyone, but it's still a sad fact to live with. Also, these numbers don't include the average of 27 minutes per surgeon spent on the EHR after clinic hours and 24 minutes on days off. The EHR was developed to make patient information more accurate, comprehensive, and accessible. The EHR has increased the number of patients seen annually, as well as total clinic revenue, but it has resulted in less face-to-face time with patients and contributes significantly to physician burnout. With this high documentation burden, a large number of strategies have emerged to decrease it. One strategy that I think almost everyone here probably uses is note templates. One study evaluated the efficiency of note templates in internal medicine. They found that the use of a best practice template resulted in notes that were rated better quality, 25% shorter, and were completed on average 1 hour and 20 minutes earlier in the day than non-templated notes. But templates aren't perfect. Functions like copy forward can perpetuate outdated or incorrect information, and templates with autofill functions can create extremely long notes with high degrees of irrelevant information. Clearly, we don't want to lose quality for efficiency. There's a balance, but I think that well-developed note templates are a good way to promote efficiency in documentation. Dictation platforms haven't been studied extensively in clinic. One study performed in internal medicine found that dictated and typed notes actually took a similar amount of time, despite providers feeling that dictation was faster. Several studies have looked at dictative operative reports with conflicting findings. Overall, dictated and templated op notes take roughly the same amount of time, but templated notes are more likely to be compliant with national standards. I think dictation is likely more efficient than manual input of an entire note, but probably similar in time efficiency when compared with templates. Scribes have been well studied across specialties. Literature from primary care medicine, emergency department visits, and outpatient dermatology clinics have consistently demonstrated reduced documentation time and improved physician job satisfaction when scribes are utilized. There are potential downsides of scribes. Patients might object to having a third party in the room, especially when sensitive subjects are discussed. But studies from PCP clinics found that 60% of patients actually like scribes, 38% feel neutral, and only 2% thought that having a scribe in the room negatively impacted the visit. Additionally, we all work in an academic medical setting where it's not uncommon to have multiple trainees in the room at a given time, and this is rarely an issue. Another concern with the use of scribes is a potential for errors, either in documentation or orders, but this has not been found in the literature. And of course, probably the main concern with scribes is the associated cost. Scribes are not cheap, but multiple studies have found them to be cost-effective across specialties. So scribes sound pretty good in all of these other specialties, but what about orthopedics? This is a study from Mayo published in 2022 looking at scribes in an orthopedic sports medicine clinic. In each half-day clinic, there were 20 to 25 patients seen. Over an 8-month period, each surgeon underwent 6 months of unscribed visits and 2 months of scribed visits. They recorded time spent on the computer and documenting, as well as self-rated surgeon well-being scores. Let's first focus on the graph in the left-hand corner. The bars to the far left show the average amount of time spent documenting after the clinic day had ended. That's 104 minutes without scribes, shown in red, and 25 minutes with scribes, shown in blue. The middle bars show the amount of time spent documenting during the clinic day. That's 87 minutes without scribes and 26 minutes with scribes. And the bars on the right show the total documentation time. That's both during and after clinic, which is over 3 hours without a scribe and under 1 hour with a scribe. So pretty substantial reductions in documentation and computer time with scribe use. Also keep in mind that this is for a half clinic day, so the differences would be even more pronounced for full clinic days. Now let's take a look at the graph on the right-hand corner. These are various surgeon well-being scores with scribe days in blue and non-scribe days in red. As you can see, having a scribe resulted in better scores across the board. Further, nurses had higher satisfaction with scribes, and the patient experience was rated similarly. One additional finding I would like to highlight is that in surveys, surgeons reported that on scribe days, they had more time to teach medical students and trainees. On a 5-point Likert scale, the average score went from 2.0 without scribes to 4.1 with scribes. So having a scribe made the difference between not having time to teach and having time to teach. I think this point is really important, particularly at an academic institution. Not only does it open up time for attendings to teach, but when the residents have access to the scribe as well, it opens up time for them to be present and to learn because they're not being bogged down with documentation tasks. That's all well and good, but again, what about the money? This is a modeling study from the University of Chicago published in 2021, looking at medical scribe implementation across specialties. They calculated the additional number of patient visits needed to recover the costs of hiring a scribe. They used data on previously reported scribe costs, as well as costs on the current market. This included an average of $3,400 in initial onboarding and a $25 hourly rate. They also accounted for scribe turnover, which we know is high. Revenue is based off of CMS national billing data for evaluation and management codes. They found that for orthopedic surgeons, they would need to see an additional 2 new patients or 3 follow-up patients per day in order for scribes to be profitable. Interestingly, ortho actually had the highest additional patient requirements. You can see this on the graph, likely because E&M codes were lower level of service compared to other surgical and medical specialties. If we take information from the previous study, where surgeons are saving an extra 60 minutes in documentation time during each half clinic day, that's roughly an extra 2 hours per full clinic day, plenty of time to see 2 new patients or 3 return patients. The other important thing to remember is that this analysis is based solely on E&M codes, which accounts for a minority of revenue generated by orthopedic providers. In actuality, seeing more patients means more tests, more procedures, and more operations, which means that costs would likely be recovered with even fewer patients. I think that realistically, many orthopedic providers run their clinics at near maximum capacity without a scribe. You just see as many patients as you can during clinic hours and write all of your notes at the end of the day. Here, the use of scribes may not actually increase system capacity or generate revenue, but if your clinic day is ending at 5 and you're not going home until 7 due to documentation, that's still time that could be spent educating, doing research, or living your life. And all of those hold value for our system. So we've just talked a lot about ways to address the inefficiencies of the EHR, which was supposed to make us more efficient in the first place. Some might wonder if continuing to add on all of these additional processes and their associated costs and complexity is actually moving towards efficiency. Or are we just continuing to add parts to a broken system and building a bigger, more complicated, more inefficient machine? This is a highly philosophical question, but one that I think is probably worth thinking about moving forward. Unfortunately, I don't have the answers. If I did, my disclosure slide would look a lot different. But I do think that templates and scribes are really just band-aids for the issue of inefficiency created by our EHR, and innovative longer-term solutions will ultimately be necessary. After patients are indicated for surgery, they enter into our preoperative pathway. Standardized pathways have been instrumental in improving the safety and efficiency of the surgical process. These pathways rely on strong relationships with anesthesia and medical providers for preoperative clearance and medical optimization. These pathways promote efficiency by minimizing unnecessary workup in low-risk patients and reducing the day of surprises that result in delays or cancellations. Having strong administrative support systems is also key in completing necessary preoperative documentation and insurance authorizations. Using nurse navigators who are involved with patients over the course of their surgical episode and assist in everything from pre-op education, discharge planning, and physical therapy scheduling, result in improved patient satisfaction and reduced costs of care. Pathways can be particularly important in the trauma setting. For example, with hip fractures, where additional testing can cause delays in patient care while very seldom changing management. And we saw a lot of success with our own Thundercat protocol here at UCSF for hip fractures. Now we'll talk about the day of surgery. Efficient use of the OR depends on scheduling of cases, allocation of staff and equipment, anesthesia time, operative time, and turnover time. We'll start off by talking about anesthesia time. Always easiest to place blame there. One way of reducing anesthesia time in the OR would be reducing the amount of time required to do certain procedures. Systematic reviews have shown that ultrasound guidance in spinals and epidurals increases first attempt success rate. It's also been correlated with reduced time of procedure, particularly in obese patients. Another way of reducing anesthesia time in the OR is to have anesthesia perform procedures outside of the OR, whether this is a block, a spinal, or induction. A block room is a dedicated space outside the OR for performing regional or neuraxial anesthesia. It allows for parallel processing. Anesthesia procedures for one patient can occur while the prior patient is still undergoing surgery, which decreases the amount of anesthesia-related time in the actual OR. You can see this depicted in the flow chart, where the top is the OR flow without a block room, and the bottom is the OR flow with a block room that feeds into the OR. In this instance, the presence of a block room results in an extra procedure performed in a day. This strategy has proven effective in multiple studies. One group from Toronto showed that for total joint arthroplasty, implementation of a block room led to a decrease of 20 minutes of anesthesia time per case, which allowed them to complete an extra case per day. It also increased the percentage of patients who were able to receive a peripheral nerve block from 63 to 87%. On top of decreasing idle OR time, block rooms may come with other benefits. Patients actually like it more. They feel they receive better explanations and have higher satisfaction ratings. Also, blocks can be performed in a more relaxed environment where the surgical team isn't staring the anesthesia team down. This can facilitate anesthesia resident education. But of course, if you run a block room, that requires the use of additional staff and space, which means higher costs. From a space perspective, the good news is that pre-op and PACU beds can easily be converted to block rooms, and this has been done elsewhere. From a cost perspective, multiple studies have shown that block rooms are cost effective. This comes from two sources. First of all, if you're able to do more cases, you make more money. But even if you do the same amount of cases and just go home earlier, studies have shown block rooms are still financially net positive. This is because you turn the lights off earlier and decrease overtime pay. There are a lot of ways of trying to optimize OR utilization through scheduling. Scheduling more complicated cases at the end of the day can make schedules more predictable and minimize next case delays. I think most everyone here probably utilizes this to some degree. Adjusting the OR schedules by moving cases to different ORs when a room is running late produces significant reductions in late case starts for those cases that are moved. However, because this is a relatively infrequent occurrence, the overall effect on efficiency is pretty modest. And from a trauma perspective, multiple studies have shown that a dedicated orthopedic trauma room decreases time to surgery for urgent and emergent cases and reduces postoperative complications and length of stay. It also decreases the number of surgeries performed after hours and reduces elective case cancellations and minutes overrun in elective rooms. This practice is efficient at level 1 trauma centers where the OR is highly utilized, while likely not as much in level 2 or 3 centers. This is an interesting study from the Netherlands looking at alternative OR scheduling. They used an institutional database to build an algorithm that optimized operating room utilization. If you look at the graphic, you can see on the left, there are 6 different ORs, each with a specific specialty booked in. On the right, the cases are rearranged via an algorithm to maximize OR utilization, and an entire OR is freed up. Now, obviously, there are issues with this. First of all, the efficiency gains are dependent on accurate case duration estimates, which we know can be variable. And more importantly, is this really how you want to spend your OR day? For the sake of example, let's substitute ophthalmology with ortho here. How would you like staggering your first 2 cases in ORs 1 and 2, then hopping over to OR 5 with a different team for your 3rd case, then waiting for trauma to finish up a cholecystectomy before you start your last 2 cases back in OR 2? Not surprisingly, you don't see too many medical doctors among this author list. That's because we all know this is ridiculous. It puts the interest of the hospital above the interest of every individual surgeon. It doesn't account for the fact that different surgeons require different setups and equipment, and it wouldn't make sense to be moving all of that around. And it necessitates that every OR team be able to perform every procedure. And we know that that's not efficient. This is a great example of how the pursuit of efficiency can backfire and make your life miserable. But it does highlight an important point. Whether you want it or not, health administrators are going to continue to pursue efficiency. And it is critical that surgeons are informed and have a seat at that table, or else you end up with stuff like this. Now we'll talk a little bit about surgical instrumentation. Studies looking at instrument usage across surgical settings have found that in a given operation, only 13 to 22% of instruments and trays are actually used. Multiple studies have shown that simplifying and standardizing surgical instrumentation for hip and knee arthroplasty can improve efficiency. This results in decreased staff confusion, faster setup times, and more open storage space in SPD. One study was performed right here at UCSF. I'm sure you'll recognize a few names on this author list. As part of a QI initiative, surgical trays for total hip and knee arthroplasty were optimized by eliminating redundant and rarely used instruments. This resulted in a decrease of 8 trays to 3 trays for total knees and 14 trays to 6 trays for total hips. This is nicely displayed in the figure. The weight of all the trays for a given setup was reduced by 50%. Setup time for total knees was reduced by 6 minutes, and estimated annual savings from sterile processing costs and reductions in OR times were about $250,000. A similar study from the University of Ottawa found that optimizing trays for total hips has significant environmental benefits as well. In addition to decreasing setup time by 5 minutes and saving $400 per case, tray optimization reduced waste generation by 1.6 kilograms, or about 3.5 pounds per case, and decreased energy utilization by 7.16 kilowatt hours per case. Just for reference, that's enough energy to power your laptop for a week straight, and that's just from one case. I would challenge everyone here in the next week or two to try and take note of how many of the instruments you're actually using in a given case. Obviously, standardizing instruments and equipment requires discussion and group consensus, but it has to start somewhere, and the benefits can be significant. Another attempt at improving efficiency has been through single-use cutting guides in total knee arthroplasty. These come in 2 major flavors. There are off-the-shelf guides like those on the bottom left. These have been shown to reduce setup and cleanup time by a total of 6 minutes, but no difference in operative time. The other type is patient-specific guides like those seen on the right. These are made before the operation. They're placed directly on the tibia and the femur, and the cuts are made through the guides. Similarly, these reduce setup and cleanup time without affecting operative time. So really, the benefit of single-use cutting guides seems to come from just opening up and using fewer trays. Also, the patient-specific guides require a pre-op MRI, 6 weeks to make the guide, and the guides themselves cost anywhere from several hundred to $1,000 and can only be used once. Overall, the time gains seen with single-use cutting guides, custom or otherwise, are pretty modest, and they come at a relatively high financial and environmental cost. So it's unclear if they're truly contributing to efficiency. Overlapping surgery, similar to a block room, achieves gains in efficiency through parallel processing. By overlapping procedures, surgeon idle time is minimized and they operate at a higher capacity. Simpler portions of the procedure, such as approach and closure, can be performed by well-trained surgical assistants, while the attending can focus their daily efforts on more complicated aspects. This not only optimizes OR time, but it also expands educational opportunities for residents and fellows. A study performed at Rothman analyzed the effects of overlapping surgery on efficiency and economics for total joint arthroplasty. They defined overlapping surgery as cases that overlap by at least 30 minutes. Overlapping cases actually took an average of 8 minutes longer and cost $300 more. That makes sense because residents were involved in those cases. But overlapping cases allow for the completion of an additional case per day, which more than made up for the small increase in associated costs. Overall, each overlapping case actually generated an additional $1,200 in revenue. So in arthroplasty, overlapping cases is more efficient and more profitable. But it isn't safe, right? Overlapping surgeries generated national attention in 2015 after a Boston Globe article highlighted a lawsuit where a patient developed paralysis after spinal surgery, and he was not aware that the surgeon had 2 operating rooms running. In reality, it's difficult to tell what effects, if any, overlapping surgery actually had in relation to this complication. What we do know is that numerous studies have demonstrated overlapping surgeries is safe and does not negatively impact outcomes. There's no effect on intraoperative complications, postoperative complications, readmission rates, or rates of revision, and this is seen across orthopedic subspecialties. Clearly, overlapping surgeries needs to be done responsibly. The surgeon must be proficient and comfortable running 2 rooms. Surgical assistants must be well-trained and competent, and there needs to be sufficient staff to support the practice. The American College of Surgeons recommends that key or critical portions of the procedure are not overlapping, but these key and critical portions are left up to the surgeon. So ultimately, the surgeon is in control of these decisions and must act responsibly. It's also important to be transparent with patients regarding this practice. First of all, multiple studies have shown that they want to know. Also, essentially all of the lawsuits that have arisen from overlapping surgeries are centered around the patients being unaware of the practice. Telling patients that overlapping surgery does not affect outcomes and the attending surgeon will be there for critical portions can be successful in abating concerns, but many patient populations remain hesitant about the practice, namely parents. Research here from UCSF found that parents of children undergoing posterior spinal fusion for scoliosis were not comfortable with overlapping surgery, not even for non-critical portions of the case. And this did not change with education about the safety of the practice or knowledge that there was a backup surgeon available. So this is likely not realistic across all orthopedic subspecialties. All right, what about this group? How do we affect efficiency? We slow things down in the OR. It varies by procedure, but it's about 20 to 25 minutes for total knees. And interestingly, the biggest difference is in approach and closure. But multiple studies across orthopedic specialties have shown that resident participation does not adversely affect surgical complications or patient outcomes. Obviously, education is fundamental to our mission as an academic medical center, so any compromise in efficiency is a worthwhile investment. And realistically, the true impact of resident involvement on efficiency has not been evaluated. That is to say, resident participation may make up for prolonged operative times with improved turnover times or help in staggering rooms. I think team structure is probably one of the most important factors when talking about operative efficiency. Studies looking at general surgery procedures from the US, Canada, and China have found that more people and more substitutions in the OR has a negative effect on operative time. This can affect communication and coordination and therefore operative efficiency. Obviously, you need enough people to get the job done, but too many can slow you down. Not to mention that reducing the number of people in the operating room reduces air contamination and surgical site infections. A study from Cleveland Clinic found that having a dedicated OR staff improved efficiency for total joint arthroplasty. Compared to traditional OR staffing, where OR staff are shared among various specialties, having a dedicated orthopedic staff reduced anesthesia time by 4 minutes, surgical time by 7 minutes, and turnover time by 8 minutes, an average improvement of 19 minutes per case. Others have suggested that a surgeon-specific team could even further enhance efficiency. These teams get used to working with each other and with a specific surgeon. Roles are easily defined to allow for parallel processing during setup and turnover, and surgical steps can be anticipated. But these surgeon-specific models may not be possible in all systems. There's also research out there that simple interventions, such as standardizing language used when directing C-arm techs, can improve efficiency. We're all aware of the variability in C-arm language. Slide north, lower down, rainbow towards me, push in, nope, just the arm. But we're also aware of the variability in C-arm tech experience in the OR. This study from UVA demonstrated that just by standardizing C-arm language, there is an increase in perceived quality of communication between surgeons and technicians, a decrease in perceived confusion in the OR, and average C-arm time decreased from 90 seconds to 50 seconds. This is an example of a very simple but effective way of improving efficiency. Let's move on to actual surgical decisions that can have an effect on efficiency. I will preface this by saying that operative decisions should be made in an attempt to optimize patient outcomes, not efficiency. Many of these topics are clinical decisions, and efficiency should take a back seat when making them, but this is a talk on efficiency, so I think it's worth touching on. Tourniquet use in total knee arthroplasty improves visualization and may have a minor effect on operative time. The tourniquet debate is fierce, with arguments about the effects on post-op pain, range of motion, and wound complications. What this really comes down to is a patient and surgeon-specific decision. Not cementing the femur in primary total hip arthroplasty is faster, and this is what we routinely do in America. But for reducing the risk of early periprosthetic fracture, there's an argument to be made for cementing more stems in older patients with poor bone quality, and this is much more commonly utilized in Europe and Australia. Cementless total knee arthroplasty is faster, and not resurfacing the patella can decrease operative time. But again, these are clinical decisions. Sure, not having to wait for cement to dry is nice, but you should not be making these decisions based off efficiency. You should be making them based off what you think is best for the patient. One operative decision that I think can improve efficiency without compromising clinical outcome is choice of suture material, especially considering closure is the longest step in most operations. There are a lot of randomized control trials looking at this in arthroplasty. They compare running barbed suture to interrupted sutures. All of them show that barbed suture results in time and material savings. Barbed suture is anywhere from 2.5 to 10 minutes faster. In terms of costs, it is at least cost neutral, with some studies showing savings of as much as $500 per case. Additionally, you have fewer needles on the field, which reduces occupational hazard, and meta-analysis has shown no difference in wound complication rates. There's also research demonstrating similar benefits of barbed suture in spine surgery. While we're on the topic of closure, another practice that can improve efficiency while closing is starting to take down the back table and get trays out of the room. This is another example of parallel processing. At high efficiency centers, once closure begins, there's only a sterile Mayo stand-up with closing supplies. The rest of the tables are being broken down and dirty trays moved out of the room. So once the patient leaves, the floor just needs to be mopped and the setup for the next case can begin. How about technology? How does the proliferation of robots and navigation systems affect our efficiency? Multiple studies show that using a robot in total knees increases surgical time initially, but there is a learning curve over which surgeons usually reach their operative times for manual instrumentation. This has been documented at anywhere from a few months to as little as 6 or 7 cases. The question then becomes whether there's clinical advantage. For total knees, robots have been shown to improve the accuracy and precision of component positioning, but the clinical benefits are still in question. O-arm navigation has been shown across multiple studies to improve pedicle screw insertion accuracy. In terms of efficiency, it does increase setup time, but the effect on operative time, at least in the literature, is less clear. Efficiency in the PACU is about reducing the bottleneck effects, where a full PACU prevents patients from leaving the OR when they are ready. This can be avoided by having standardized pathways and criteria to keep patients moving either to discharge or to the floor. Regional anesthesia can also contribute by decreasing PACU length of stay and increasing the likelihood of discharge home. I think culture is the most important factor when discussing efficiency. At the end of the day, the success of any of these strategies is contingent on the ability to successfully implement and execute them. And this requires appropriate leadership, buy-in, and support. A big part of culture is having buy-in from the team, which requires an alignment of incentives. In some systems, this is baked in. In ambulatory settings like the OI, the staff and the anesthesiologists leave when the last case is done, so they're motivated to be efficient. In hospital settings, staff and anesthesiologists generally work shifts where there is no incentive to be efficient. In fact, there can be an incentive to go slower so you don't have to do as much during your shift. Here, you need to find other ways of motivating people. Research has shown success in financial rewards for first case starts and decreased turnover times. And many high efficiency centers have teams assigned to certain ORs and financial incentives to complete a certain number of cases by a certain time. Another part of this culture has to be viewing efficiency as a process. You have to constantly measure and evaluate the process in order to improve. You also need to make sure you're measuring and rewarding the correct metrics. For example, measuring and rewarding percent operative room utilization can actually incentivize slower surgery because surgeons just want to demonstrate they're using their block time. Another example is how we define on-time starts. At UCSF, this is generally measured as in-room time. But at a lot of high-volume centers, they measure it by cut time, which changes the focus from just getting the patient into the room, where we know delays can abound, to actually getting the surgery started, which is what we really care about. Your data also needs to be granular enough to act on. If you just measure wheels in to wheels out, you lose details on anesthesia, positioning, draping, surgery, closure, and wheels out. This allows you to identify specific problems and target solutions. And when you do establish benchmarks to strive for, they need to be realistic and attainable. Moving on to the postoperative pathway. Similar to the preoperative pathways, efficiency in the postop pathway is predicated on standardization and strong relationships with anesthesia, medicine, and physical therapy providers. Postop pathways have been consistently shown to decrease pain, improve mobility, and shorten length of stay. A big part of these pathways is consistency. Having consistent teams who are familiar with protocols and are telling patients consistent information on what to expect post-op. All it takes is one traveling nurse to tell a patient that they're in too much pain to work with PT or go home to derail this system. There's also been a trend towards outpatient surgery, particularly in arthroplasty. In select patients, this can reduce resource use in the hospital and free up beds without negatively impacting outcomes. Discussing preoperative expectations can help set the stage for postoperative efficiency. In one study, telling total hip patients in clinic that they will discharge on post-op day 2 instead of post-op day 4 decreased length of stay by a day. Prehabilitation, though not shown to improve functional outcomes in arthroplasty, has been shown to reduce length of stay as well. And preoperative psychosocial interventions, especially patient education and relaxation techniques, have also been shown to decrease postoperative pain and length of stay after orthopedic surgery. And finally, we'll talk about follow-up. COVID expedited our capabilities for telehealth, and this is a great opportunity to provide more efficient follow-up care. A randomized trial comparing in-person and telehealth follow-up in total knee and total shoulder patients found that telehealth visits were an average of 8 minutes faster for total shoulders and 12 minutes faster for total knees. There's also good concordance between range of motion values obtained in person and via telehealth. And there was no difference in patient satisfaction. Another way to be more efficient in the follow-up period is to eliminate unnecessary visits. A growing body of literature shows that routine one-year follow-up for primary arthroplasty is rarely clinically useful, despite accounting for a high time and cost burden. Even just by making these annual appointments PRN, a surgeon could significantly cut down on their follow-up volume, freeing up valuable clinic space to see new patients. Similar studies for postoperative hip fracture patients has called into question the frequency of routine follow-up visits. They're inconvenient for patients and nursing facilities, and they rarely change clinical management. Research shows that when there are changes in treatment, they're almost always initiated by concerns from the patient or other providers, as opposed to being picked up during routine orthopedic follow-up. So let's revisit the surgical process with a new set of eyes focused on efficiency. Let's say a 65-year-old patient calls with a complaint of 1 month of knee pain. Through a triage algorithm, they are scheduled to see an AHP in clinic within 2 weeks, where non-operative treatment is attempted for 3 months. At that time, the patient has not seen meaningful improvement, and they're referred to an arthroplasty surgeon who has availability for a clinic appointment within 2 weeks because more of their clinic space is open for operative candidates. The patient is seen in clinic, a scribe writes the note, and they're scheduled for surgery. The surgeon finishes clinic at 5 that day and leaves with no clinic notes to speak of. The preoperative team takes over scheduling and obtaining authorization. The patient is scheduled for surgery within 6 weeks and undergoes appropriate preoperative workup and clearance. They arrive on time on the day of surgery. They receive a pre-op block and a spinal and are in the OR by 7:15 for a 7:30 cut time. The surgeon, with their regular team, performs a safe and efficient joint replacement consistently under 90 minutes skin to skin. As the resident closes the wound at lightning speed using barbed suture, the turnover process has already begun, and the attending is headed next door, where the next patient is prepped and draped with another resident ready to cut skin. The first patient hits PACU, where PT sees them as soon as the spinal wears off. They discharge home that day with prearranged home health PT and a nurse to check on them post-op day 1. They have follow-up scheduled at 4 weeks in person, 3 and 6 months via telehealth, and then PRN thereafter. The surgeon ends up performing 6 arthroplasties that day and is home by 4 to coach their kids' soccer game. I know this sounds like a dream, but these systems do exist and they are attainable. Here are a few of my references. Thank you. Thank you all for your attention. I also want to take a moment to thank all my faculty mentors with a special shout out to everyone who gave input for this talk. Dr. Diab, Dr. Ward, Dr. Berry, Dr. Beanie, Dr. Feely, Dr. Lansdowne, and Dr. El-Habadi from afar. I also want to say thank you to my co-residents, particularly the R4 class. Y'all are the best. And finally, thank you to my wife, Sonia. We got married in November. Then I went to Tanzania for 5 weeks, and she's had to listen to me talk about efficiency ever since I've been back. So appreciate her.
All right, congrats, Dr. Warwick. That was great. And I think a lot of good takeaway points. I'll start with Dr. Wostrak here.
Hunter, thank you. That was a really excellent talk, just so well done. And I really appreciate that you focused on the patient outcome and the physician experience over financials, because I think it's very easy in a talk like that to just talk on financials. So thank you so much. That was great. I have a question. Was there any literature about the cognitive load increasing when you're hyper efficient, and if there's any negative side to that? So if you're doing 4 inefficient cases during a day versus 7 efficient cases as a surgeon, is there any downside to that?
I did not find anything particularly on that. However, I guess just anecdotally, speaking with people who work at high efficiency centers, their days are more, I think predictability is kind of the main thing that kind of reduces that cognitive load. If you go in and you know that you're going to do 7 cases, but they're all going to be pretty predictable and you're going to be done at a predictable time, that can make a big difference as opposed to kind of going into the abyss and you have 4 cases, but you don't really know how things are going to go or what's going to happen. So I think predictability is kind of the main kind of cognitive metric there.
Because I would just say, as a very inefficient person in an inefficient subspecialty in a not so efficient hospital, I do use that time to round. I do use that time to catch up on other things and get a chai latte and things like that. So I mean, I wish we were more efficient, but then I still would need to round at some point in that very efficient day. And when would that happen? So it's just, I don't have an answer, but just things I think about.
Yeah, I think everyone's system's a little different. It sounds like you actually are efficient. Just
Dr. Warwick, thank you for that incredible talk. So many questions and thoughts stirred from all those different topics, but I'll ask 2 questions. The first is, how do we shield patient care from the capitalist machine? I feel like I'm just thinking what Dr. Diab would think and asking that. But I feel like a lot of efficiency measures are driven to increase profit and then justified by patient care, right? And that's kind of how things work in general in our society. But so that's one. The second is, how do we improve surgical education in a setting where efficiency is driven and optimization is driven so highly, and that affects both the attendings trying to teach as well as the residents?
Yeah, absolutely. No, great questions. So the first question, yeah, I think that's kind of the concern, right? We want to be efficient, but we need to keep it in check. I think especially with private equity moving into the orthopedic space, these firms are focused on consolidation, efficiency, and cutting costs. So really, as physicians, we need to have a seat at the decision-making table, and we need to make sure that these gains in efficiency don't compromise the actual clinical process. They don't compromise our autonomy or patient safety. So it's difficult, but yeah, it's all about just making sure that you have are sitting at that table. In terms of resident education, I totally agree. I think the knock on most efficient residency programs is that they aren't focused on resident education. If you'll notice, like most of the things we talked about today actually didn't have much to do with the actual operative time. Most of the things are about the time surrounding the operative time. And I think improving that efficiency in that realm actually holds great benefits for residents. First of all, higher volume means more cases, better protocols means fewer pages from nurses, and more patients going home means fewer patients around on. So I think there are benefits to be had, but obviously we have to be smart about how far we want to go.
Thank you. It was a great presentation. I'm an engineer. I'm thinking about it from the perspective of the people who wrote that paper about OR utilization.
Yeah.
And you started with an equation of output divided by input, which led to that kind of analysis. Have you seen studies, or do you have suggestions about how do you factor, a provider satisfaction, for patient satisfaction into an equation about efficiency that would help have a more holistic analysis in future studies?
Yeah, no, it's a great point. So that study was, they was modeling, and I don't think they actually implemented that, or I hope not. But yeah, again, I don't have a great answer for how to formally, integrate it in. I think that's, continuing to measure patient satisfaction, like for scribes, is an important part of actually having that, voice be kind of formalized in the literature. But yeah, I do think that is something that is paramount moving forward, is making sure that physicians have a voice with these changes being made.
Hunter, that was a great talk, very thoughtful. I have 2 areas I'd like you to comment on. First of which is payers. So part of this is driven by lower reimbursement, right? So the more efficient you are, the less time it takes, the less we should pay you, because you can do a total joint in 25 minutes. We're not going to pay you as much, and it becomes a cycle. So if you could comment on that. And then the second question is, I think, more of the global question of healthcare costs rising unsustainably. How much of that is due to our inefficiency versus something else?
Yeah, two very good questions. So the first one in terms of payers. So yeah, we've seen decreased reimbursement for total hip and knee arthroplasty as we've gotten faster at doing them. Obviously, that's not great for the individual surgeon. I think for the system, it doesn't mean that we should stop trying to be efficient. I think it just means that advocacy is going to play a more and more important role as moving forward. So as surgeons, we need to make sure that policy and reimbursement both reflects our work and also doesn't begin to infringe on our ability to take care of patients to the best of our ability. And then, sorry, remind me of the second question.
Efficiency is great. So, and healthcare, I think the global problem is healthcare costs rising, right? How much of that is due to our inefficiency versus others?
I see. Yeah, I mean, I totally agree. I think a lot of it is probably due to just more, we're just using more and more tools and they get more expensive and we're doing more surgery. And it's interesting because actually there's a study from Japan that showed that for an individual surgeon, the greatest predictor of their efficiency wasn't any individual characteristic. It wasn't their experience. It was just their fee schedule. So I think that is a very big motivator. And I think that gets down to, obviously fee for service incentivizes more volume regardless of quality, whereas pay for performance, that kind of brings efficiency and quality into the equation. So it's about doing more with less or doing the same amount with less. And it's about ensuring that you're maintaining a certain level of quality care. So I don't think that there's definitely more problems in the health system than inefficiency, but I definitely think that it's something that we can control and contribute.
Awesome. Hunter, I'll echo. Amazing talk. I think you took something that could be seemingly not as interesting, very interesting and applicable to all of us. And I like how you focused on things that we can do as surgeons, like the barbed wire. And honestly, anecdotally, I've heard a lot of X-ray techs go, some people say up, some people go down, wag, see, which one is it, blue, And so I think that is something that we can do instead of blaming others for simple things that we can do to make a case run smoother. I think one thing that you highlighted that I also feel like is a big hurdle is like break time for the surgical tech. So, it's classic, you're on the most important cut and you turn around and you're like, oh, well, doctor, I'm going on the break, so-and-so taking over. And then they're looking for the drill or they're like, I don't really know the setup. And so is there a system or have you found something in which for, understandably, for a front back spine, the same person's not going to take a break, but for a case that is 3 hours or a certain amount of time where that scrub tech does not take a break and maybe someone else, in order to mitigate that, someone else does the setup for them or so they are getting their break when there's turnover so that you can be with the same person, like back to your team approach for the entirety of your case.
Yeah, no, that's a great question. I didn't find anything specifically on kind of mitigating the effects of the nursing break. I think those are really big barriers to break down with unionization and kind of, bureaucracy. But I totally agree. I think that if there's a way to have staff work on a case basis as opposed to like a, more shift-like basis, then that has obvious gains in efficiency there.
Hunter, thanks. And excellent commentary along the way. You and I talked about what you mentioned. Drucker Janeway, another finance guy, said that efficiency is the antidote to creativity, and you didn't spend as much time on that. But when I think about like percent GDP, the military is the greatest, and medicine is right behind it. And the military has always been used as the quintessential example of inefficiency. It's the most inefficient system in America because it has to be ready all the time. And I've often wondered whether American medicine is also, like just like our military is the greatest in the world, so is our medicine. And it might be because we are somewhat inefficient and therefore very creative And as you go through this and try to make us all more efficient, we run the risk of losing our preeminence and our creativity. I mean, we put so much value on innovation, and yet we're trying to absolutely maximize and efficientize everything. We run that risk.
Yeah, I think we absolutely run that risk. There are definitely limitations to, how far we can go. As you mentioned, we need a diversity of ideas, but that's extremely inefficient to have a bunch of people saying different things. The most efficient government is a dictatorship. Just one person says what to do and things get done. But I don't think we want that in medicine. So it's all about balance. It's all about finding, more efficient processes without sacrificing, a certain degree of innovation and creativity.
Thanks, Hunter. Just one couple of points real quick on perspective. I think you could eliminate the reimbursement part of the consideration and make it access to care. And I think most, if not all, of what you said would still apply. And I look at our own situation here in San Francisco, where we're resource constrained and we have long waiting lists. So money aside, you can't ever completely put it aside, but we still have an imperative to be more efficient and give more people access to the services that we provide. The other point I wanted to emphasize is the leadership perspective on this. These things don't just happen because we think they're good ideas. Any program that's had any success, like Thundercat or bundled care or standardization of spinal equipment, required incredible amounts of leadership effort and teamwork. And so I probably don't have time to go into that in detail, but I was interested in your thoughts, and maybe for all of us to think about who leads this, who does this. I think probably the conclusion would be, well, the surgeons need to be part of that, but it's the commitment of time and effort, and where does that fit in the day? The rewards are great, but the requirement for the leadership and teamwork and planning that is at the front end of this is a huge part of the success.
Yeah, no, I couldn't agree more. I think, we're talking a lot about financials here, where high upfront cost, but over the time, it ends up paying out. And I think the same could be said with, manpower and with, leadership. You have to really put in a lot of work up front, but if you kind of see, the horizon and see where you want to be, then it's gonna require that kind of down payment of your time. It's also, I completely agree. It's the surgeon has to be the leader. You can't ask for an efficient culture and not be part of it. So some of that might be even on the ground, being in the room to help set up or helping to mop the floor after the case. There's actually studies that show if the surgeon is in the room, turnover is faster. So I completely agree that the surgeon has to be at the head there.
All right. Well, thanks again, Dr. Warwick. Great job, and enjoyed your talk. Congrats.
Awesome. Thanks, everyone.